Good morning, good afternoon, good evening from where you're joining us. It's wonderful to have received more than 500 registrations for today's webinar. And as you know, the current webinar dedicated to the synergies of sepsis and AMR is organized by the Global Sepsis Alliance for the first time for medical students. And we are convening this event in partnership with the International Federation of Medical Students Association, the largest network of future medical professionals. And we are also delighted to have IFMSA's representative among the faculty. Special thanks goes to bioMario, the educational grant of bioMario made organization of this satellite session of the World Sepsis Congress possible. So we are grateful for the long-standing partnership and look forward to future collaboration. It's my absolute pleasure to moderate today's session with the brilliant speakers from United Kingdom. Dr. Ron Daniels will be joining us soon, as well as Professor Imrana Malik from the United States, two of the most experienced, not only the clinical practitioners fighting sepsis in their daily lives, but who bring amazing perspective from the national responses to sepsis. And we will be joined by two amazing friends of the Global Sepsis Alliance, Shahrzad from Sweden and Graham from United States, who have personally gone through the experience of facing sepsis and surviving sepsis. And I believe that you will learn a lot from the interventions that we look forward from Shahrzad and Graham. Without much ado, I would like to start the session with a brief presentation on the Global Sepsis Alliance, because as mentioned, this is the first webinar for medical students. The audience is new for the Global Sepsis Alliance network, and I believe you would be interested to learn a bit about our network. The Global Sepsis Alliance, so this is our today's webinar banner with the faculty. And briefly about the Global Sepsis Alliance. The Global Sepsis Alliance was established 15 years ago, and this organization is behind the World Sepsis Day movement. Many of you might have heard of September 13 as the World Sepsis Day. And today, the movement engages more than 54,000 supporters from 170 countries. GSA was behind the historic sepsis resolution in 2017 that was adopted by the World Health Assembly. And the photo on the slide is a historic one with Margaret Chan, the former Director General of the WHO, and Professor Konrad Reinhardt, the founding president of the Global Sepsis Alliance, on the day of the adoption of the sepsis resolution. Finally, the Global Sepsis Alliance is the initiator of the World Sepsis Congresses. This is the annual online congress that has already reached over 122,000 attendees, the healthcare professionals, policy makers, researchers, innovators, and sepsis advocates. As an example, last year, our Congress has reached 11,800 participants from 174 countries, and traditionally we are honored to be joined by Dr. Tedros Ghebreyesus, Director General of the World Health Organization, and other high-level panelists at the opening session of the Congress. I hereby use the opportunity to invite you to our next Congress that will be held on April 22 and 23, completely online, completely free of charge. GSA is represented by 122 member organizations in 6 geographic regions. We have regional sepsis alliances in Africa, Europe, Eastern Mediterranean, Asia Pacific, Caribbean, and the partner organization in Latin America. GSA's experts are continuously providing technical expertise to WHO and other global health authorities in refinement or updating the sepsis clinical management guidelines, both for pediatric and adult populations. And as mentioned, we are representing sepsis survivors and families, and here you will see Shahrzad's impressive photo. I'm sure she will speak about her personal experience in more detail later today. The photo also shows Ilse Malfait from Belgium. Both Shahrzad and Ilse have made very impactful change in their own countries in driving sepsis advocacy and changing national policies. And finally, GSA has led the development of the very first multi-year global strategy for sepsis, and the document was launched at the German Parliament last year with the presence of our strategic partners from Virchow Foundation, Unite Parliamentarians Network for Global Health, as well as the Sepsis Stiftung. And we were honored to have the special video address from Dr. Tedros specifically for launching the 2030 Global Agenda for Sepsis. Why is this document so important? If we successfully implement the 2030 vision for sepsis, we would be able to save at least 2 million lives every year by 2030 and avert at least 12 million new sepsis cases, not to speak about the important economic gains that could be associated with the reduced morbidity, mortality, and disability from sepsis. I also use the opportunity to invite you to join the Global Sepsis Alliance as individual members. This is the new platform that we opened in November, and everyone, starting from medical students or other students, healthcare professionals, or just those who think that sepsis is the global cause that we all have to be united by. You can join us through the GSA's individual membership platform. And you will be able also to receive individual membership certificates, appreciating your contribution and efforts in making the world free of sepsis. Finally, let me share 4 slides as an introduction to our session on the interaction of sepsis and AMR. Unfortunately, not every physician or every future physician knows that sepsis affects almost 50 million lives every year and is responsible for at least 11 million deaths. Those are the figures that are currently recognized by the World Health Organization. Sepsis, based on WHO and other global health authorities as recognized figures, take every 5th life or are responsible for 20% of deaths worldwide. And it's really surprising and difficult to understand why the medical emergence and the global health threat that takes 20% of lives is not adequately visible in the global health dialogue and partnerships. But this is the status quo we want to change. More recently, in October, the Institute of Health Metrics and Evaluations and the Oxford University collaborators, they published the latest estimates on sepsis based on the 2021 modeling exercise. The latest estimates say that sepsis in 2021 took 21.4 lives. More than 21 million people died of sepsis directly as a direct cause or as an intermediate cause. And 166 million people were affected by sepsis. We shall remember that this is still the pandemic period, and many of the deaths caused by COVID-19 were, of course, related to viral sepsis. Based on this latest estimate that is not yet officially recognized by WHO, that's why I'm separating those 2 estimates for your easy reference. Sepsis-related deaths, all-cause sepsis-related deaths were accountable for 31.5% of total global deaths in 2021. Another set of data that would be important to keep in mind for today is that based on the Lancet publication and the data, again, recognized and published by the World Health Organization, antimicrobial resistance was estimated to be responsible for 1.27 million deaths in 2019, and that has contributed to 4.95 million deaths. And finally, the slide that you should remember. The Institute of Health Metrics and Evaluation and Oxford University researchers, based on the latest Lancet publication, estimating that sepsis took 21.36 million deaths in 2021, also estimate that those 21 million deaths included the the 4.71 million deaths associated with antimicrobial resistance and 1.14 million deaths attributable to antimicrobial resistance. So when we speak about AMR and not speak about sepsis, this is this should be changed, because sepsis is the human face of antimicrobial resistance. Unfortunately, we speak a lot about AMR. That is wonderful. AMR should be positioned high, should be consistently prioritized, but AMR and sepsis dialogue, AMR and sepsis policies, both at national levels as well as the clinical management level, should be synergized and synchronized. I thank you for your attention, and I now have the pleasure of handing over to Anna Liakopoulou, the liaison officer from the International Federation of Medical Students Association. Anna, thank you very much for being with us. GSA is delighted to have the new partnership with IFMSA, and we look forward to hearing your perspective as the young medical professional. Thank you.
Thank you so much. And thank you for organizing this webinar with us. Let me share my slides. I think you can't see the full screen. Let me try again. Yes, okay. No. When we tried earlier, it was working.
Yeah, sometimes it happens. So let's try again. Now we see it.
But you can't see the full screen. Okay.
Anna, if you could maybe, yeah, now it's good. Yes.
Okay. Okay, I can present like this.
Mhm.
Okay, perfect. Sorry for the technical issues. I'm Anna. I'm from IFMSA. I work on the topic of medical sciences and research, and of course, some of the areas that we're working on is sepsis and AMR, and we're very happy to be working with Dr. Jashi and the Alliance. I will also do a short introduction about IFMSA. In case you haven't heard of it. So IFMSA is an international organization built by medical students for medical students, and our vision is a world that medical students like myself and like you are capacitated to take on leadership roles for global health, and they have the knowledge and skills to take up on these roles. IFMSA was built in 1951, so this year is the 75th, is going to be the 75th anniversary. We have more than 1.5 million medical students as members worldwide in more than 125 countries. And we have a lot of local activities being done by our member organizations. Our structure is divided in 5 regions: the Europe, Eastern Mediterranean, Asia Pacific, Africa, and in Americas. And we divide our work into 6 pillars, six standing committees for medical education, all the way to human rights, SRHR issues, and our exchanges programs. So our activities are on a global and on a local or national level from our members, but internationally we do the exchanges program. We have our general assemblies and regional meetings, and we're there every year at the World Health Assembly doing also a workshop to prepare medical students to participate more actively. Going to the topic of today's discussion, of course, which my topic has the title From Classroom to Clinical Reality. Let's see a little bit about the medical student's perspective from what we have seen on sepsis and AMR and what is the situation in the curricula. So the first thing that I actually want to mention is that sometimes sepsis feels like panic for medical students because the first time that we hear about it is not in a classroom, it's not in a calm environment, but it's when there's a patient in a very critical situation. So it's already in a very advanced stage, it's already too late, and this is where we understand that, oh, this is what sepsis is. This way, we don't really know how to detect the early signs, which is very important, and we're going to talk about later. And of course, as Dr. Jashi mentioned earlier, sepsis is connected with AMR. It's of course it's by AMR it can lead to sepsis, and it's not direct, but it when we don't have the right antibiotics when there is resistance, things get complicated. But in the clinical context, it's not exactly like this. So there is uncertainty in the clinical practice that we see also as medical students. There are early signs that are being missed, diagnostic that take a lot of time, uncertain follow-up. We might have patients that cannot come because they live too far, so they can't come back, and we're going to prescribe them antibiotics just to be sure. But this will will increase the AMR, and this leads to a dangerous circle where we have late diagnosis, broader antibiotic use, and then more resistance. And resistance makes it harder to fight the infections, and the infections, of course, will lead to sepsis. So this is why it's very important for us to understand the early signs and have early detection. So in our education, we do learn about sepsis, but as I said, mostly in the late advanced stages, and we do know about AMR. It is different in the clinical practice, so this is a little bit confusing for students, but also we don't know a lot about how these two pillars intersect and how we can tackle them in our practice as future doctors. What our members have seen is that they have seen patients from post-operative infections dying because they didn't have access to the right antibiotics, or young patients coming late to the hospital when it's already in a very advanced stage. And of course, these gaps are also connected with access, preventions, and readiness of our systems. There might be inadequate water, sanitation, or hygiene, limited diagnostics in some areas, unreliable supply chains for the antimicrobials, and overcrowded facilities that limit very much the time of the doctors, so they're going to prescribe because they don't have enough time to assess the situation. So when these gaps exist, infections progress, antibiotics fail, and sepsis become more and more harder to prevent. So why it's important for us as medical students to discuss and know about these things? We're there every day in the wards, in the hospitals. We interact a lot with the patients. We take their vital signs. We talk to them. So it's easier for us to notice deterioration early. And of course, in the future, which is the most important thing, we're going to be the ones prescribing antibiotics. We're going to be the ones that need to assess a patient and understand the early signs of sepsis. So what we feel that needs to change is to being taught more talk more about sepsis, not only when it's urgent, not only when we're in a rush trying to save a patient, but calmly just to understand what are the signs and try to detect them. Secondly, of course, to have antimicrobial stewardship as a core sepsis skill, not just a theoretical concept. Be assured and try to make decisions under uncertainty. This is soft skills, which is another thing that most medical systems in education lack, because it's not just theory, it's something that you learn in practice. And of course, to have an environment where students are involved, when students can talk and they can express if they see any of these signs. So what we are doing currently, and what most of you might be doing in your countries, across our communities, we're taking action, we're doing peer education, we're doing awareness campaigns, we have community outreach, and through the exchanges program, there are students in critical care units seeing sepsis patients, and they understand more about their condition. So we need to use these experiences to shape how sepsis and AMR are taught in our medical schools. We need to be there, present, we need to discuss, we need to be the ones that are bringing change and support further all these things that we're doing. And closing, I wanted to mention that as medical students, we are not just preparing for the futures, but we're here right now. And it's great to have all these people joining this event today to understand more. And this is the first step for you to take things back to your university, to your local community, and bring change from there. Thank you so much. And if you have any questions, here is my contact details.
Anna, thank you so much for your excellent presentation and really bringing the perspective, the actual world experience of medical students, how they see the sepsis and its interaction with AMR. And we are again delighted to have this partnership, and we really hope that through IFMSA we will be able to reach more medical students, spread the word, circulate the latest news and evidence-based knowledge. And more importantly, we hope that through closing this education gap, we would be able to reduce the panic caused by sepsis among the students and young professionals. And I believe that our next speaker, Ron Daniels, is the best person and professional who can really help us start bridging that gap. Ron Daniels is the CEO of the UK Sepsis Trust and the board member of the Global Sepsis Alliance, re-elected for the next triennium. And I sincerely wish to see every country as proactive and successful in national sepsis response as the UK. Of course, many of our colleagues would say that there are still challenges. Of course, there are always challenging, but what Ron has really championed together with his colleagues and friends in UK is truly historic, and we look forward to hearing from you, Ron. Over to you.
Thank you so much, Mariam, and thank you for the kind introduction. And it's incredible to be able to reach so many medical students from all around the world, and to hear a wonderful introduction from a student colleague. So as has been introduced, I work both within the UK and globally in the space of antimicrobial resistance. And I think that's important, because antimicrobial resistance until recently hasn't really had so much of a voice. And I think we who take an interest in sepsis can help to bridge that gap, as well as the gap that Mariam's discussed. Now, this has already been presented, and these data, and I'll illustrate it in a slightly different way. 166 million people affected globally, with 20 million lives lost. Now, that is 31.5% of lives lost worldwide are from sepsis. the final common pathway to death from most infectious diseases worldwide. Now, we need to remember that these are estimates, and it's possible that this number might be ever so slightly too large, but it's certainly approaching the right number. Now, it doesn't really matter whether the billion, it's in that ballpark. The quanta are huge. This is a condition that claims more lives around the world than cancer. Now, in my country has a population of around 70 million people, similar to many other European countries, Germany, France, Italy, Spain, and so forth. It's a football stadium full every year. This is the home of Villa Football Club. Breast cancer in the UK claims around 11,000 lives every year. Bowel cancer claims more lives, claims about 16,000 lives. But estimated 58,500 people in the UK die every single year. There are country-specific data within these reports, 61,000 in Italy, for example. 34 find the estimate of the numbers of deaths. Now, how we define sepsis, I think we need to acknowledge that it's a slightly artificial construct, this sepsis thing. Obviously, infection is very common. Severe infection, requiring
So Ron Daniels was joining us from the airport, and apparently we have a technical error in connection. Let's hope that Ron would be able to join us very soon. In the meantime, let me use the opportunity to once again invite you to the Global Sepsis Alliance individual membership platform that was recently launched. And I would like to demonstrate the slide that brings to you also the QR code for your easy reference. We're speaking about young generation, young professionals who are so much advanced in the technologies. And we really hope that many of you would be happy to join us, to join forces in fighting the global threat that takes at least 20% of lives worldwide, and based on the latest estimates, almost 1/3. Let me, since Ron might need more time to come back, Imrana, would you mind to present your slides, and we hope to have Ron Daniels back as soon as possible. It's my absolute pleasure to introduce to you Professor Imrana Malik from the United States. Imrana is also the second-term member of the Global Sepsis Alliance, and her expertise and leadership is especially interesting in the areas of sepsis and cancer, immunocompromised patients area. Imrana, over to you.
Thank you so much, Mariam. I really appreciate this opportunity to speak today and to share about a very huge topic of antimicrobial resistance and sepsis in vulnerable patient populations. So we'll dive right into this. When I was making these slides, I was trying to think of what exactly I wanted to teach medical students about sepsis among vulnerable patient populations, as well as in the setting of AMR, and that in 15 minutes. So the first teaching point I have is that we have to have a higher suspicion for sepsis and treat even more urgently in this vulnerable population. So what are these vulnerable populations? According to World Health Organization, these are individuals with extremes of age, pregnant or recently pregnant women, people with weakened immune systems, and those with chronic medical conditions. And then certainly the individuals who have been hospitalized, especially in the ICU settings. And what these populations have in common is that they may have immature, weakened, or impaired immune systems that contribute to their vulnerability. And specifically for those hospitalized patients, they may undergo surgical procedures or have invasive medical devices that put them at higher risk for infections. Now, the higher suspicion for sepsis is something that we have to have because sometimes the identification is very difficult, especially in the vulnerable populations, because the signs and symptoms may be atypical, or they could be attenuated, such as in cancer patients who may not be able to mount a fever or a leukocytosis response to infection. The lab values or the vital signs may differ among the populations. For example, in pregnant patients, the white cell count, the heart rate, the blood pressure, the respiratory rate may be elevated as a norm. So we have to have different cutoffs for monitoring those individuals for sepsis. And in children, these findings can be very age dependent. In addition, there are several settings in which sepsis can be mimicked. So, for instance, in HLH or hemophagocytic lymphohistiocytosis, a big word, there is an increased immune trigger response to non-infectious etiologies such as cancer or autoimmune disorders, but also to various infections such as Epstein-Barr virus. Other mimics include cytokine release syndrome, which can be seen in CAR T-cell therapy for cancers. Now, in terms of treating these individuals more urgently, we know that the vulnerable populations see a higher mortality for sepsis. And you see some of these ranges here, but the higher end of these ranges, we can see that in populations that have a higher burden of sepsis, such as in sub-Saharan Africa. And as we've heard earlier, the estimate that we sort of compared to is this 31.5% of sepsis mortality globally based on the 2021 report. We always want to keep in mind AMR when we're treating sepsis, whether in vulnerable populations or not. This is very important because one of the key links in the sepsis chain of survival is the treatment of infections with antibiotics. And the microorganisms that cause these infections have been at work at creating resistance for over 2 billion years. They've been doing this with intrinsic resistance, which is encoded in their bacterial genomes in response to toxic substances over time, but also from selective pressures that we have instilled on them with disinfectants and our use of antimicrobials. Secondly, they've used acquired resistance through horizontal gene transfers of different elements, such as plasmids that encode resistance elements. And then sociopolitical drivers that we have created also contribute to the development of AMR with our overprescribing of antibiotics, as we know that approximately a third of antibiotics prescribed in the US were inappropriately prescribed. And patients may also not complete these treatments, which contribute to AMR development. Our overuse of antibiotics in livestock and fish farming, as well as poor infection control within hospitals and clinics contribute. And then, as we know, lack of hygiene and poor sanitation really increases the burden of infection and therefore the push into more AMR. And finally, as we try to increase the pipeline for new antibiotics, we find that we're still very lacking in these developments, and that creates the opportunity for AMR to continue to develop. When we take a look at the world map of AMR by location, I've highlighted a few areas where there is a particularly increased abundance of AMR. And then when we overlay this with the map of sepsis incidence by location, it's not surprising that the two types of locations coincide. This is a timeline of the emergence of antimicrobial resistance based on the 2023 UN Environmental Project report. And you can see that as we discover and then commercialize the antibiotics, soon after, we see the emergence of antimicrobial resistance. And sometimes it's very quick, as in the case of linezolid. And sometimes we do have a couple of decades of use of these antimicrobials, such as with vancomycin cephalosporins, where we have some time before the resistance starts showing up in the clinical setting. And then when we take a look at some of those rates across countries, median AMR rate for third-generation cephalosporin-resistant E. coli is at as high as 42%, and for MRSA as high as 35%. And rates are anticipated to increase twofold against those last resort antibiotics by 2035. That's only 10 years from now. So it's very concerning. So what are the impacts of the resistant infections? So based on the 2016 review on antimicrobial resistance, which was commissioned by the UK government, we see that the mortality rates can double, as can the treatment costs when there are drug-resistant infections found in these patient populations, whether those are vulnerable populations or not. And the projection is that AMR by 2050 may cause up to 10 million annual deaths, which would surpass the deaths that we're seeing based on all cancer types currently. In addition, as expected, this would increase economic costs with a total GDP loss of over $100 trillion. So what the next teaching point is that vulnerable populations can be more susceptible to these resistant organisms. And there's a lot of examples of this, and I'll share a few research papers on this. So challenges that relate to critically ill neonates. We find that up to 14% of gram-negative bacterial infections in the bloodstream produce extended spectrum beta-lactamase. And these infections then subsequently increase hospital stays as well as mortality rates for these neonates. In pregnant women, we see an increase in antimicrobial resistance as well, with organisms spanning gram-negative as well as gram-positive categories. And then for cancer patients, we find that up to 3 times higher isolates are discovered from outpatient settings in cancer patients compared to those without cancer. And finally, amongst the elderly population, there's an estimate of 35% of nursing home residents having been colonized with multi-drug resistant organisms. So next teaching point is that the antibiotic pipeline is currently inadequate for the level of resistance that we are dealing with. And in 2017, WHO shared their prioritization list for pathogens, and at their top critical priority pathogens, we see Acinetobacter, Pseudomonas, and Enterobacteriaceae that are carbapenem resistant, as well as the Enterobacteriaceae that are third-generation cephalosporin resistant. There's a list of the high priority pathogen candidates as well as moderate priority pathogen candidates as well. And when we compare that to the list of the antibiotics that are in preclinical and clinical development, we see that there's approximately 45 of these in the traditional category. This is from 2021, and 32 of them in the non-traditional category, which encompasses sort of bacteriophages and immune modulating agents. But in the traditional category, we see that there are only about 3 of them that truly directly address the critical priority pathogens identified by WHO. And that's really concerning and worrisome. We need more pathogen-directed antimicrobials for these critical pathogens identified by WHO. In the meantime, We have seen more new molecules that were approved almost yearly since 2017, as well as combination agents. So as an example, dilofloxacin or eravacycline from classes that are known to us as fluoroquinolones and tetracyclines have emerged. And then more recently in 2025, aztreonam avibactam combination medication. And one that we were all very excited about in 2019, which is cefidrocol, which covers all three of the critical pathogens identified by the WHO. Now, when we take a look at what's coming down the pipeline, we also have triple combination agents showing up. This is a combination of meropenem, avibactam, which is a serine metallo-beta-lactamase inhibitor, plus a metallo-beta-lactamase inhibitor. These combinations, as you can see, showed a lower minimum inhibitory concentration in bactericidal activity than just a dual combination when they tested on a panel of 51 Mariam-resistant bacterial strains. Unfortunately, it doesn't work as well for Acinetobacter or Pseudomonas, but does cover the Enterobacteriaceae categories. And then finally, my final teaching point is that we can and we absolutely must change this trajectory in terms of AMR in all populations, not just the vulnerable population. We know that sepsis hand in hand with AMR transcends geographical boundaries and has significant global impacts, which if we are not to change this trajectory, we're headed towards potential failure of our last resort antibiotics. These are the reserve group of antibiotics identified by WHO. And if we end up in that situation, this is very dire, and we can be talking about pre-antibiotic era where common bacterial organisms were less sensitive or really untreatable in the past. And we definitely do not want to find ourselves in that situation. But we have an opportunity to try to change this trajectory. And some of the things that we can do is learn from what our successes were during the COVID-19 pandemic in terms of our ability to be much more targeted in our approach with timely source identification and interventions directed at the organism and its complications. And what that could look like for sepsis is that we could have more rapid pathogen detection of the different infection subtypes in sepsis, as well as having an approach that differs from a bundled type of care, which is very non-specific. In COVID-19, we had advances in health informatics that were very rapid as well, and we could leverage that as we go forward, and robust collaborative research in addition to using the AI format. And then finally, AI can help us with machine learning as well as deep learning. And we find that this was happening for us in our research during COVID, where we used it for a diagnosis of bacterial infection. We've started using it in drug development, where we discovered new molecules using the drug repurposing hub. Using it for resistant mechanism prediction, as well as antimicrobial stewardship, where it can aid in empiric antimicrobial therapy decision making. What the best case scenario would be if we find a patient coming in with an illness, we're quickly able to identify that there is presence of infection, the type of infection that we have, and if they have a particular resistance pattern. And we need this to be done within hours of presentation and be available in all settings, not just high income settings, so that it really affects where the sepsis burden is the highest as well. We're very familiar with this reduce, reuse, recycle pathway that's shared when we talk about environmental safety and protections. But this could also be applied to AMR, where we sort of rethink what we're doing with AMR and how we manage antimicrobial stewardship, what we use in terms of combination and novel drug development, the requirement for rapid pathogen detection and facilitation of our approaches using AI as we go forward, as well as new research strategies that help us personalize the treatment. We can repurpose what we already know in terms of existing medications and using them for their new antimicrobial mechanisms of action, as well as the approach of engineered bacteriophages for resistant organisms and the use of pre and probiotics to kind of enhance the work of our good bacteria. And the use of immunotherapies beyond what we do with vaccines, and learning from what we know has been successful in CAR T-cell therapy, as well as immune checkpoint inhibitors in cancer patients. And then finally, to re-engage with the population with this information by bringing the results of these drugs to the patients directly through universal access and improvement of this access, through education and awareness, and through challenging the leadership at national or regional levels to improve regulations. And then to reassess how we're doing by surveillance methods. For example, the GLASS system, which is WHO's global AMR and use surveillance system, to ensure that we're doing continually better than we have been in the past. So in summary, we have to have higher suspicion for sepsis in vulnerable populations because identification can be very challenging. Sepsis mortality rates can be significantly increased among vulnerable populations, as we shared earlier. And the presence of resistant infections increases mortality rates and costs of care in all populations, especially in vulnerable populations. And the incidence of AMR is definitely rising among these groups. Investment in more robust antibiotic pipelines is crucial before we hit a failure of last resort antibiotics. And we need to learn from our successes in the past, especially with COVID-19 pandemic, in terms of rapid pathogen detection and personalized approaches, leveraging data systems and AI to improve screening, management, and drug development, as well as utilizing novel trial designs with more prognostic and predictive enrichment strategies. We absolutely need tools that identify infections and AMR patterns very quickly, within hours. And we need to change this trajectory of AMR. And this requires, in part, significant changes in how we manage sepsis, because they, as you heard, they go hand in hand. These are not parallel. These are very connected pathologies. And with that, this is my slide for references, and I thank you for your attention.
Thank you, Imrana, for this amazing presentation and really highlighting both the complexity of the sepsis the theme itself, its interaction with AMR, and how holistic and truly multi-dimensional our approach should be to really solve these two very closely linked global health threats. Wonderful. And I'm still looking through the chat. So far, we have greetings and thanks from different countries. We have participants from Argentina, Trinidad and Tobago, and Asia. And we look forward to hearing from other participants currently online.
That was your 550. Yeah,
yes.
Nice.
And now, Ron, back to you. Hope your flight schedule allows us to have your presentation fully.
Thank you, Mariam. And look, I'm so sorry. It's, as you can see, I'm in the airport and there was a poor connection. So I'm sorry to all of the people listening. So just very quickly to recap, sepsis is an enormous problem. It's an enormous problem globally. In the UK, for example, it's around 48,500 lives lost. In Italy, for example, it's 61,000. Iran, it's 34,000. I did BBC Iran recently, so I looked at their data. You can find all these data for yourselves. I came on to the fact that sepsis, the definition globally, is a slightly artificial construct. So this scoring system, the sequential organ failure assessment score, is the current criteria with which we define a sepsis at a research level. It's not very useful clinically, in a busy emergency department because it's quite difficult to calculate. It requires a significant amount of information. But it applies the same thresholds whether somebody is 18 years old and athletic or 88 years old and has not been out of bed for the last 10 years. So it's slightly illogical. It's an artificial construct, and it doesn't recognize that sepsis is a very heterogeneous disease. And we need to understand how we can more precisely define sepsis at the very least, a cohort level, so that we can begin a move toward precision medicine and therefore help us to spare the antimicrobials that Imrana was eloquently talking about. Now, many of you will know that we have international academic guidelines for sepsis, and they were most recently updated in 2021. We are due further updates in the very near future, but I have it on good authority that there won't be any very major updates. Now, one of the most major things, and again, this touches on what Imrana was saying, was from an antimicrobial stewardship perspective. We've known for many years that the evidence around very early antibiotics in people with sepsis is primarily in people with septic shock. And there was much less evidence in people who had sepsis without shock. So the Surviving Sepsis campaign proposed a very pragmatic, to my mind, approach, where if we see someone that we suspect as having sepsis, we only have to ask ourselves two questions. Number one, does my patient have shock? If they have shock, we treat with antibiotics within 1 hour. Number two, if my patient does not have shock, how sure am I that this is sepsis? If I'm quite sure it's sepsis, give antibiotics within 1 hour. But if it's one of those many patients for whom sepsis is one of a list of possible diagnoses, then we allow a more generous window of 3 hours, allowing us to make sensible decisions around antibiotics, perhaps even if they do need an antibiotic, making a right choice about appropriate antibiotics rather than going straight in the broad spectrum. And this has got to be the right approach for antimicrobial stewardship. And I would propose that this is almost the first step toward precision medicine in this very heterogeneous condition. Now, we can't forget people who have infection but not sepsis. So these are data from Europe, and they looked, this is from the SOAP study, they looked and they found that these 4 sources of infection, pneumonia, urinary tract, abdominal, skin and soft tissue, bone and joint, account for 95% of episodes of sepsis in high-income countries in the Northern Hemisphere. Now, obviously, in subtropical regions, this list will be very different. Diarrheal illness and diseases like malaria will be at the fore. But in high-income countries, it's these 4 sources. Now, in England, what we did is we looked at our hospital episode statistics. And so these looked at all admissions within England within 1 year that were either caused by or complicated by one of these 4 infections. And it's a huge number. And this will be similar in your country, if your country has a similar population to my country. 1.7 million hospital admissions in 1 year in England. This is not the United Kingdom, this is just in England. Now, this is important, again, for the reasons Imrana was mentioning. All of these people, remember, these people have cellulitis or pneumonia or a urinary tract infection that's necessitated hospital admission. They will all receive antibiotics. And I think we need to stop thinking of antimicrobial resistance as being our fault. Antimicrobial resistance is a natural evolutionary consequence of our desire to stop humans coming to harm from infection. We need to do all of the things that Imrana was talking about, but I think we need to just recalibrate this slightly. We need to give resistance a face. We need to give it a human face. We need to make it immediate. We need to make it personal so that our children, in whichever country we are, see it as just as important as plastics in our ocean, because it really is. And we've got to change the mindset. We've got to stop criticizing doctors for giving antibiotics to too many people. We've got to grow up with our approach to antimicrobial resistance and include consideration to the use of antibiotics and the inappropriate use of antibiotics in agriculture, particularly in intensive farming. Sepsis is a chronic disease. We need to begin to think of sepsis differently as well. It has suffered from being described as a syndrome, but this is a chronic disease. We know factually that people who survive sepsis have disordered immune regulation for many years afterwards, have an increased incidence of development of autoimmune disease, for example. This is a chronic condition. This was a nice little study in Northern Europe, and it found that if people were admitted and they were in full-time employment before they had sepsis, they were admitted to hospital with sepsis, at 1 year, 57% of them were back at work, although many of them had reduced their hours or were in a different role. 43% had not returned to work at all. So we have to rehabilitate them. And in the UK, we do this through our charity. I think because we're short for time, I thought what I should do is to talk about really what I think will happen in the future. Perhaps not in my career, but certainly in your careers. Many of our countries have national action plans, and Mariam at the beginning mentioned the World Health Organization resolution on sepsis that we got passed in 2017, and we're very proud of that achievement. And it resulted in calls to member states to develop national action plans across all 186 nations that were delivering against this. Not all of them have done it, but many have. So England is now in its third iteration. Again, I've just chosen some European countries. France have national action plans. Switzerland have a national action plan. There is investment in these countries. France has allocated 50 million euros to sepsis improvement work. Switzerland has a smaller population, but they've invested 5 million Swiss francs, which is similar to 5 million euros. Portugal don't have a national action plan, but are having concerted efforts at improving their outcomes from sepsis. But I would argue this is not enough. We need to not accept people with sepsis as being the poor relatives of people with stroke or heart attack or major trauma. For all of those other conditions, in the vast majority of high-income countries, there has been significant investment. This is an example of what happens in England, that if a hospital can provide care in an acute stroke unit, rapid imaging and rapid thrombolysis, for every patient they treat, they get 64% more money reimbursed by our government. So that's a couple of £1,000 or a couple of €1,000 for every single patient. And that's resulted in investment in service provision. This initiative resulted in our developing acute stroke units, the role of the stroke physician becoming normal, 24/7 access to CT scanning and MRI scanning, which didn't previously exist. We need the same for sepsis. Now in England, it has just been announced last week that we are now doing this. England is going to have what's known as a modern service framework for sepsis, and there will be enhanced remuneration at this sort of level for hospitals delivering the very best care to our patients. But this needs a new paradigm. This needs almost a service redesign. Now, I talked about a move toward precision medicine. We have to accept that not every patient with sepsis needs to be in intensive care. And in a country like the UK, actually, relatively few end up in intensive care. So if we have a SOFA score of 2 points or more, then yes, those patients will be cared for in intensive care. If they don't have, if they're not exhibiting overt organ failure, then why shouldn't they, just like our stroke patients, just like our heart attack patients, be treated in specialist non-intensive care areas? So we've been planning within England, within the NHS, that we build sepsis units where people can have a small amount of vasoactive medication. Perhaps they can have high flow nasal oxygen, that they don't need intensive care levels of organ support. So we're talking about developing the sepsis unit. If they don't need that, then they can, as happens now, go to the hospital ward, as we call them, or floor, as some other countries call them. But what about home care? So let's say someone has a technical diagnosis of sepsis. They have an infection, perhaps it's a urinary tract infection, but they're only ticking the sepsis box because they have an example, an acute kidney injury. They don't need to be in hospital. If they don't need dialysis or hemofiltration, then why can't we keep these people at home? They can have regular intravenous antibiotics if they need them. They can have wearable technology to monitor their vital signs and other information be collected by wearable technology. They can have scheduled reviews. And the shift within the NHS is to keep far more patients out of hospital and monitor them at home. So again, this is a paradigm shift that we're seeing in the UK. And we can start to cohort our patients according to the severity of their sepsis, including in these sepsis units. I think what our governments need to do is to start to think about infection management holistically. Sorry for the very long web address there, but to start to think about infection management together. At the moment, too many governments think of antimicrobial stewardship in isolation from sepsis, in isolation from infection prevention, and in isolation from disease surveillance and pandemic preparedness. These are all activities which are in the business of saving humans from infection. And at a policy level, we need to consider them together, I would suggest. I think the thing that's going to happen first is the diagnostics revolution, bringing diagnostics much closer to the patients, rapid diagnostics to help us to risk stratify patients, decide whether or not it might be a bacterial infection, and to identify pathogens more quickly. And these are not the best diagnostics. They're just 3 companies I happen to have worked with. But diagnostics are going to get much closer to our patients' homes, much closer to prescribing clinicians. We're going to see less centralization in laboratories. And we need to accept that sepsis is very heterogeneous. Craig, who's now Lord McKinley, was a parliamentarian when he developed sepsis. He was well at lunch. By tea time, he was in intensive care in multi-organ failure. So within a small number of hours, he deteriorated. I don't think any hospital in the world could have saved Craig's limbs. His care was excellent, but I think many hospitals could have allowed him to lose his life. Martha was very different. This is another high-profile case in the UK. Martha was 13 when she died after a 48-hour deterioration. She died because medics failed to take her slow deterioration seriously, but it was a very different condition, to Craig's. This is an old paper. There are hundreds of papers out there about the different phenotypes and endotypes of people with sepsis. But, this gives us as much information as many of the newer studies. And it really drives us that we must acknowledge that Martha is not the same as Craig. Patients present with different disease profiles, and we need to begin to understand this much, much better. And we can only do this through data and through artificial intelligence, but through proper application. Now, in time, this might allow us to activate new therapies for discrete cohorts of patients. So we might learn, for example, that Martha would have benefited from a monoclonal antibody. We might have learned that Craig might have benefited from an old therapy called activated protein C, which seemed to work in people with rapidly progressive sepsis. This precision medicine move is critically important for our antibiotics, but also for other specific treatments. And just to finish, artificial intelligence is of course here now. It is of course being applied and sometimes over-celebrated. So this is from Johns Hopkins University, and they, as you can read for yourself, they said that in 82% of sepsis cases, the AI was accurate nearly 40% of the time. Well, that's not good enough, because if we don't have humans assessing this, that will mean that 60% of patients started on broad-spectrum antibiotics might not actually need them. So it's not there now. We must remember that artificial intelligence is right-brained. It's not left-brained. It's not creative. That human thought is still necessary. And the academic community urges us to exercise caution. But I think in time, in countries like Switzerland, like the UK, like Western Australia and others, where we're already exploring big national registries and artificial intelligence evaluation of the data coming in, we will start to move towards this. It will definitely happen during your careers, and I think we're starting this journey right now. But building AI into electronic patient records, better understanding of how we can use biomarkers, use the sciences of proteomics, genomics, and so forth, that we will move toward precision therapy, just as we can for people with cancer now. And that will happen very quickly indeed. So thank you so much. I'm sorry my gate's been called, so I'm unable to attend the Q&A in a little while, but I am available at ron@sepsistrust.org if anyone would like to ask me a question. Thank you so much.
Ron, we cannot thank you enough, especially for joining right before boarding the flight. And thank you so much again, having the oversight of the massive impact of sepsis on individuals, on health systems, on economies. and how we have to really merge urgently the dialogue on AMR, sepsis, and other infectious diseases. Thank you so much for your experience, expertise, and insights, and we will let you go. And if we have any questions that will be directed to your presentation, we will catch up later with you and come back to our participants. All the best, Ron. Thank you. In the meantime,
Thank you for the kind invitation, Mariam.
Always a pleasure. In the meantime, we have been joined by participants from Bangladesh attendees, Greece, Kurdistan, Georgia, my homeland, Nigeria, Rwanda, and Zambia, and greetings to all the medical students joining us from all around the world. And from the experts' presentations, we will now move to even more important part of our session. We will hear from people who have personally gone through sepsis experience and learned from them. And the first is Graham Segars, who, while being a student himself, was affected by sepsis, and we look forward, Graham, to hearing from you. Thanks for joining. Over to you.
Thank you so much. So yeah, like we were just discussing, I am a student who unfortunately went through a time where I was diagnosed with septic arthritis. It was about a year ago, and it was just one of the hardest things I've ever had to overcome. So kind of to start off my story, while I was at work one day, felt like a completely normal day. A few hours within my work, I took a break and went out of the car to rest. When I got up to head back inside, I felt a pop in my hip. I tried to walk it off and keep going, but with every step, the pain got worse. Quickly walking went from uncomfortable to nearly impossible. I had to leave work early. When I got home, it escalated even more. I could barely make it up the stairs. My mom met me halfway down the stairs, and I ended up crawling the rest of the way. I went to see a nurse practitioner who told me it was just a pulled muscle. There wasn't an x-ray or a thorough exam, and my hip was barely even evaluated. I was even reassured that I'd be fine on going to my upcoming trip to New York, but I definitely wasn't. That Tuesday, I still took the trip. Even though I used crutches to move throughout the airport, the pain was so severe I could barely use them. At the airport, we ended up putting me in a wheelchair because I couldn't walk. When I arrived in New York, I tried to stay optimistic. Maybe it would calm down by the next day, but unfortunately, it just didn't. I saw a doctor in New York, got an x-ray, and they referred me to an orthopedic specialist. I decided to wait and follow up when I got back home with my own doctors. In the meantime, my friends rented me a wheelchair and ended up pushing me through New York because I couldn't get around on my own. When I got back home, I scheduled an MRI for that Friday. After the scan, we were told that the MRI had been lost. It was eventually found, and I was told I had arthritis in my hip. A procedure was scheduled the following Monday to drain the fluid from the hip and test for infection. That Monday, that just happened. They drained the fluid, and later that evening, we got a call that changed everything. The fluid was infected. I needed to return back to the hospital immediately. The next day, I had emergency surgery. During that surgery, they found severe damage. My bones were rubbing together, tearing through the cartilage. Around that time, I went into septic shock. Thankfully, it was caught and treated. I spent 5 days in the hospital on IV antibiotics, and I went home with a PICC line to continue IV treatment. After the hospital, the recovery became the next battle, and this part people don't always picture. I had to relearn how to walk. For about 3 months, I did physical therapy multiple times a week, working through basic movements most people take for granted: standing, stepping, balancing, because my body had basically shut down around that hip. It was my senior year of college. Even though it was summer, I quickly realized I wouldn't be able to return for the fall semester on time. My college didn't really have virtual accommodations, but I worked with them to make it happen. A home health nurse came weekly for blood work while I was still on the IV antibiotics, and physical therapy stayed intense because I was determined to get back on my feet. I eventually returned to school September 30th, still using my walker and crutches. After a brief evacuation because of Hurricane Helene, I then returned for my senior year and down only to one crutch. So why do you think I'm sharing this with medical students? Because for me, sepsis didn't look like the stereotype. It started with pain, it was sudden It was sudden and severe that progressed very fastly. There was multiple points where a deeper evaluation, especially when I couldn't bear weight and the pain kept escalating, could have changed the timeline. My takeaway is simple. When a patient tells you something feels seriously wrong and the story doesn't fit a routine explanation, slow down and widen the differential. Ask the questions that feel unlikely, because sometimes the unlikely diagnosis is one that could save the life. So I'm here today because septic shock was recognized and treated in time, and I'm sharing this to you. I want you to remember sepsis can happen to someone young, healthy, and seemingly low risk, and it can start with a symptom that is easy to dismiss. Thank everybody for listening.
Graham, thank you so much. And we are so glad that in your case, even though diagnosis took some time based on your story, it's still, you had full recovery and you're back to your studies, you're back to your life. And most importantly, thank you for getting in touch with us, the Global Sepsis Alliance, with your willingness to share your story so others could learn. And I believe the medical students who are currently attending the webinar, they hear from you, they learn from you, and they will be more kind of attentive of the potential sepsis diagnosis. And as you rightly said, something really feels wrong. So that is very common, the description that patients and parents of the patients also describe. So thank you so much. And I just want to also reflect from the chat that we are also joined from Cameroon, Italy, Armenia, another participant from Nigeria. Overall, the faculty and participants are representing 17 countries of the world. And I believe that you all will find this as a very good experience to learn and exchange. Finally, last but not least, it's an absolute delight and pleasure to hand over to Shahrzad Kiavash. She's the sepsis survivor and athlete who is one of the strongest voices in the fight against sepsis. Originally from Iran, currently living in Sweden. And Shahrzad, thank you for always being with us, for always being on the front kind of line of the fight. And I'm sure the audience would be astonished by the story you can share.
Thank you so much, dear Mariam, for that kind presentation. And thank you very much for being here today and having me. And when I was 28 years old, I was completely healthy. I was working, I was independent, I was training at the gym. I had a very normal life. But, you know, no chronic illness, no risk factors, nothing out of the ordinary. But one day I was at the gym and I had this terrible, I don't know, like a worm that was squirming around inside my stomach. And I thought that I had caught the flu. But then during the night, it escalated and I had other symptoms. And I called the emergency number and they came. The ambulance came and I told them, I don't know what is happening, but it feels like I'm dying. I had an elevated heart rate of 144, but all of the other parameters were correct. So they told me that I was having a panic attack and that I could go to the psychiatric ward if I wanted to. Turned out that I wasn't having a panic attack. I was going into septic shock. A few hours later, my brother fortunately found me on the floor and my face had turned blue and I was unconscious. And everything just shut down and fortunately, this time they took me to the hospital and I got provided the care that I and my body needed. But I was very, very sick. And when my parents came, I was hooked up to a ventilator. I was in the hospital for 7 months, was operated on 53 times. Unfortunately, the doctors couldn't save my legs, so both of my legs were amputated below the knees. And just as Graham said, I had to learn everything from the beginning: how to sit, how to stand, how to breathe, how to eat, everything all over again. But it turned out that that was only the beginning. And here I just want to be very clear with you. I am not here to tell you about how strong I am. I am here to tell you about how important you are. The decisions that you make, the decision to listen carefully, to act early, to listen to the patient, to notice the subtle changes, that will be the difference between life and death. Not death just like in a dramatic sense of being or not being, but the death of dreams, the death of limbs, the death of independence and future plans. It took me years, many years, but I eventually found my way back. I became a Paralympic triathlete. I competed in the Rio 2016 Paralympic Games. And when they took my legs, they told me that my right arm wouldn't make it either. It would never be the same. Right arm swam in the Atlantic Ocean all the way to Copacabana Beach. But the thing here is, I am not everyone. I live in a high-income country with great healthcare, and not everyone had the support system that I had. Not everyone gets a second chance. There are so many voices of sepsis that you will not be able to hear because they are not here anymore. So I want to leave you with that. You can make such a difference when you meet your patients. And will you see the early signs? Will you listen to the patient? And will you make the difference in someone's life just the way that my doctors made a huge difference in mine, and why they are the reason that why I am sitting here today, even being able to share my story with you. So I hope you get the benefit of a patient telling their story, that you were the one who saved them. And with those words, thank you very much for having me, and back to you, Maria.
Shahrzad, this is not the first time we were together in the panel, and every time it's amazing how you have this amazing way of conveying the message. And I mean, I've heard your story so many times, but every time it never leaves you untouched and shocked what you have gone through. Thank you so much. And we also have the flood of hearts on the online channel, and sending much love to you from Joyce, and greetings from South Africa and Poland. And I think that your address was exactly what we need, you know, how, and reassuring our medical students, our future professionals, how important they will be in saving lives in their everyday practice. And since sepsis, the killer of 1 in 5 people, 20% of death is at least, if not higher, based on our latest estimates. And making sure that sepsis becomes much more visible, receives more attention, and we're more cautious and more prepared to identify the initial signs properly, timely, because every minute matters, not to say every hour. So I'm so grateful, Shahrzad, another brilliant speech. And
Thank you.
again,
Thank you so much.
great presentation. Thanks for sharing. Thank you for your presentation. So those are the messages from the chat. We don't have any questions till now. I believe that audience enjoyed the speeches, the presentations, the experiences shared by our brilliant panel. Professor Imrana Malik from United States. Thank you so much, Imrana. Dr. Ron Daniels, who had to run to catch his flight, but who has really done, who is doing a great job in the United Kingdom as the CEO of the UK Sepsis Trust. Graham from the United States, Shahrzad from Sweden, our dear Shahrzad, and Anna, our new colleague, young colleague, and a partner from the Institute of the International Federation of Medical Students Associations. And in the conclusion, let me once again share the platform of Global Sepsis Alliance. If you were inspired by today's presentation, if you think that as a medical student, as the future physician, you can make a difference and you would like to join the fight against sepsis, this is the way where you could join the GSA, become the associate full or honorary member of the Global Sepsis Alliance, and unite forces against this devastating medical condition. So thank you once again. And if you have any questions, please do not hesitate to contact the Global Sepsis Alliance, and we could also link you up with any of the speakers at our session. And finally, special thanks to our partner organization who made this session possible, bioMérieux. We have been collaborating with bioMérieux on a number of education grants, as well as the World Sepsis Congress, the World Sepsis Day movement. So we're grateful for the ongoing collaboration and look forward to the future opportunities. Thanks to everyone for joining us today. All the best, and of course, the best wishes for New Year and the festivities.